The treatment I chose was virtual environments used for cognitive rehab with TBI patients, and this topic interests me because deficits in executive functioning can be devastating, and helping patients regain these skills is a huge step towards improving their quality of life. The hypothesis of the study was that TBI patients with cognitive impairments could benefit from the virtual reality technology and training for situations in which their safety is at risk. 30 subjects were studied, ages 19 to 48, with acquired brain injuries residing in residential facilities. They used a software called Softhaven to assess the cognitive functions involved in basic activities of daily life, and the environment they chose stimulated a typical kitchen with standard objects and appliances, and the specific task they examined was preparation of a can of soup, which involved 30 different tasks that were scored on a 6-point scale, 6 being that the correct response was achieved after 1 or 2 mouse clicks, and 1 being that the response was not achieved after 5 attempts. Scores ranged from 30 to 180, with the higher score indicating a more successful performance, and the scoring of the responses was done automatically by the program and took into account response time as well. And the results were measured using an intra-class correlation approach and a coefficient of variation. The authors concluded that with repeated assessments, scores consistently improved, showing the effectiveness of virtual environments to practice executive functioning tasks like memory, judgment, and sequential planning, and these findings indicate that the virtual reality kitchen shows acceptable and reliable potential as an assessment and training device for TBI patients, and one strength is that the therapy was administered to each subject twice within 7 to 10 days to ensure test-retest reliability. Also, the subjects did not report any side effects from this, like there was no simulation sickness or dizziness, and authors implemented a good use of visuals and graphs as well to make the results more easily understood, being that the ICC and CV values were difficult to understand. And the therapy also can be reconfigured to more closely resemble the anticipated real-life environment of an individual after discharge. One limitation of the study is that the sample size is small, and being published in 1998 is a little outdated, and it was conducted when technology was in its infancy. And lastly, the study does not account for other possible deficits that result from a TBI, like gross motor difficulties, time orientation, and impulsivity that may occur outside of the training session. And based on all the evidence and data collected, there's a linear relationship that was evident between the scores obtained over time, showing improvement with practice. And the therapy works by scaffolding to provide prompts and cues to assist the task completion, and when the client begins to improve, less prompts are used, showing an increase in independent task completion. And something I still want to know are how long and how frequently do patients typically have to use this therapy before they can safely return home. I'm also curious to find out how difficult or easy it is to generalize these skills across contexts, and how frequently is this treatment used now, and what advances have been made with the expansion of technology.